My name's Bill Schroeder, and I've been a practicing sonographer for many more years than I'd like to admit, both in a hospital setting, in a physician office, as well as a private outpatient facility. I'd like to call this little presentation the quick scan. If you do venous studies, I know you've heard this line. I know you have a full schedule, but can you please just do a quick scan on this patient, make sure they don't have a DVT? So my objectives for this talk are to lay out the scenario and then make my argument that there really should be no such thing as a quick scan. Well, the term quick scan probably arises from the uninitiated in that watching a skilled sonographer perform an exam, it looks pretty easy. They don't really appreciate the nuance and how difficult it really is. But it may also have some roots in a paper that was published 10 years ago in which compared a 2-point ultrasound plus a D-dimer study versus a whole leg ultrasound in diagnosing suspected deep vein thrombosis. Now, this was actually a very well done prospective randomized and carefully controlled multi-center trial out of Italy. They looked at more than 2,400 ambulatory patients presenting with a first episode of suspected symptomatic DVT. And they compared ultrasound of the common femoral and popliteal vein with a whole leg examination. If you look at the results in this chart, there were 231 patients, or 22%, that had a positive ultrasound or a positive D-dimer. Of those, 217 had a positive ultrasound. However, 31%, or 256, had a negative ultrasound and a positive D-dimer. In this case, the patient was recommended to have a repeat ultrasound in 1 week, apparently to look for progression of disease up into the popliteal. At that 1-week ultrasound, 5.5% now had a positive ultrasound. However, we can also note that only 0.9% had pulmonary embolus. For the patients that had the whole leg ultrasound, you can see that actually 65 or 26% had an isolated calf vein thrombus. However, in this group, only 1.2% had a pulmonary embolus. So the conclusions for this study was largely there was no difference in the 3-month incidence of confirmed venous thromboembolism, and therefore the long-term outcome was fairly similar. They concluded that the 2-point ultrasound coupled with a D-dimer was equivalent to a whole leg ultrasound for management of these patients. And of course, the conclusion was detecting an isolated calf DVT might not be as relevant as we want to believe based on the low incidence of pulmonary embolus. So what are the pros of each? The 2-point compression was simple, convenient, and readily available. It was performed by the emergency room physician after a short training. Average length of study was less than 4 minutes. Compared to the whole leg ultrasound, provided the definitive answer, and it certainly was admitted to be advantageous in patients with isolated calf complaints, those patients that were unable to return for a serial exam, because remember, a lot of them were required to come back for a complete ultrasound, and also consider a whole leg ultrasound in those very high-risk patients. How about the cons? Well, 2-point compression requires a repeat ultrasound in as many as 1/4 of the patients. The whole leg, of course, is technically more demanding, limited availability if you don't have a sonographer available or at night on call. It's more expensive, and it may expose patients to the risk of anticoagulation, possibly deemed unnecessary in the case of isolated calf vein thrombosis. Well, let's look at a couple of cases. Here's an acute DVT in a common femoral vein. We can see transducer compression, distended vein, incompressible. This is pretty easy to diagnose. So patients that present with an acutely swollen leg are much more simple to evaluate because we're looking for obstruction in the major veins. Patients that present with possibly a little swelling but pain in the calf are much more difficult because we have to look at the calf veins. Now, sorry, we don't see all the calf veins as good as in this image. However, we must remember that ultrasound is in fact the gold standard for evaluating veins. We can see most of the veins in most people. A couple of pictures from the common femoral vein. We see wide color filling in the upper left, compression images in the lower left. We see kind of a normal spontaneous with respiratory phasicity, Doppler spectral waveform, and how I like to look at the confluence of the femoral vein, seeing the femoral and the deep femoral confluence into the common femoral in the lower right. Of course, our standard is transducer compression. Along the left-hand side of this slide, you see proximal, mid, and distal femoral veins. They all compress with transducer pressure because oftentimes in the distal femoral, transverse is a little tricky to get good visualization. We like to also document with a longitudinal view and assess color filling. In the upper right, in the proximal femoral vein, we have calf compression, and we do see augmentation. However, it's a little suspicious. Should be a little bit better than that, don't you think? Okay, how about the popliteal? Compresses very nicely, good color filling, widely patent. The peroneals can often be a little bit difficult to compress due to their proximity to the fibula. You have to take care to not have the fibula taking up the weight of that transducer compression. But here we can see pretty clearly that that posterior vein to the artery does not compress with transducer compression, and we confirm that with a couple of longitudinal images. We can see color filling very nicely in the anterior vein. The deeper vessel looks distended and no color filling at all. This is consistent with acute thrombus. Here's another patient with an acute thrombosis of a gastrocnemius vein that extends into the popliteal vein. Now, the gastrocnemius veins can often become quite large. They typically do empty into the popliteal vein. Now, we shouldn't miss this one because of the extent into the popliteal vein, but if you're doing lower extremity venous studies, gastrocnemius views should be part of your protocol. And that goes for the soleal veins as well. Here's another acutely thrombosed soleal vein. This is an image from the scan plane depicted on the anatomic image, kind of a posterior lateral approach, which is really good for looking at the peroneal veins. If you're confused, pay attention to the muscle, not so much the vessels. Look for the medial and lateral head of the gastrocnemius muscles. If you see a vein there, usually they're paired with arteries. That's a gastrocnemius vein. If it's in the soleal muscle, it's a soleal vein. Also look for that dilated hypoechoic structure. If you need more help, I got a full lecture on calf vein evaluation on Virtual Vein Center. How about this? A perforating vein thrombus. Now, we probably don't have time to search for all the perforators, but note the distended hypoechoic structure. Also, another hint, scan where the patient says it hurts. How about this one? I'm not even 100% sure what this vein is, as it extends from the gastrocnemius muscle in through the soleal muscle. We can follow it very clearly. The vein is incompressible, and actually a tail of thrombus does extend a little bit into the peroneal vein. I had not noticed this until I came across this image. I did not see this in the peroneal veins from both a medial and a posterior lateral approach. And in fact, this patient was referred for a, quote, quick scan, unquote. I did tell the referring physician if I had performed a quick scan on his patient, we would have missed this. Of course, the rationale for looking for isolated calf vein thrombus is whether or not those patients need to be anticoagulated. Now, I'm not going to present all the research. You can do that for yourself. But when I looked at it, the treatment or anticoagulation was basically largely on 3 lines of evidence that I really found far from compelling. I will give you one study by Landefeld published in JAMA in 2008, and he found a 3.7% propagation rate in untreated calf vein thrombosis. So my argument is it's much better to know if in fact the patient has an isolated calf vein thrombosis. That allows the clinician to make an informed decision whether or not to treat that patient based on their risk of propagation, which of course is the immediate concern, that and pulmonary embolus. This is not even to mention the potential long-term consequences of valve damage and chronic venous insufficiency. It's much better to know than to adopt the stick your head in the sand method. Finally, if you're not using the Wells clinical prediction algorithm for deep venous thrombosis, I strongly suggest that you get this and use this. This can prove to be your best friend. So I guess you can gather, I am not a big fan of the quick scan. If a clinician asks me to do a quick scan, I'm wondering if they'd bring their mother or their spouse or their child in for a quick scan. I believe we should be doing one type of scan, and that is complete according to our protocol and to the best of our ability. Thank you so much. Hope you enjoyed.